A very good afternoon, everyone. Good afternoon, judges, seniors, and my dear friends. I'm grateful for this opportunity and thanks to my mentors for their constant guidance and support. So my topic is transconjunctival intra levator triamcino for the upper lid retraction and thyroid eye disease. Thyroid eye disease, as we know, it is an enigma. The most common disease that affects the orbit. It is complex, and yet it is poorly understood autoimmune pathology. It affects, basically, it's an autoimmune mechanism which ultimately affects all the things that are present in the orbit, starting from the fat, the muscles, as we know. And the complications that can happen is lid retraction, myopathy, proptosis, and optic nerve dysfunction. Also, we know that it has a natural course of the disease. There's a dynamic phase, which is the active phase, and the static phase, which is like the inactive phase, which is commonly known as the Rundle's curve. The most common eyelid symptom that we encounter here is eyelid retraction, which is seen in 90% of the cases. What is the mechanism of eyelid retraction? Well, overaction of levator and Muller's muscle, which is because of the increased sympathetic tone or the fixation duress, the levator hypertrophy, levator muscle contracture or fibrosis, abnormal adhesions between levator and surrounding structures, scarring or inflammation of the septum and the anterior lamella. So the challenges that we face are functional, which can cause lag of thalamus or exposure keratopathy, or cosmetic, which can actually be a psychosocial impact for the patients. And the management options that we have in our hands are either surgical or non-surgical. Okay, but the question here arises is what to choose, when to choose, how to go about it, what are the results that we get with these things, and how many injections or the surgeries that are required, and when do we do it, whether in the active phase or the inactive stage. So as we know, surgical treatment can only happen during the inactive stage when the fibrosis has set in, which is unpredictable, it is irreversible, it is invasive, it can lead to under or overcorrection, and definitely it leads to it can lead to inadequate lid contour. The non-surgical options in our hand are botulinum toxin, hyaluronic acid gel fillers, and triamcinolone. So we focused on the role of triamcinolone injection in our study, and we evaluated its role in lid retraction in thyroid eye disease patient. It was a retrospective interventional case series of 37 eyes of 22 patients from January 2019 to August 22, and all the patients underwent the triamcinolone injection in an OPD setup using a Demar's retractor. We evert the lid, and subconjunctivally we give this injection for the upper lid retraction. The analysis is as follows. We had the maximum age group fell between 36 to 45 years, and the mean age was 46.2 years in our patients. Females were more, 13 more than males, and bilateral disease was more, that was 13 seen in 13 of our cases. Maximum of our cases were hypothyroid. Otherwise, hypothyroid and euthyroid status was also seen. The disease was active in 6 cases and inactive in 16 cases. So the result was the mean number of injections that was required was 1.7 with a range of 1 to 4. Maximum number of injections that was required was between 1 to 2. Mean average dose was 23.7 milligrams, and time to maximal response was a mean of 37.6 weeks. And all the values that we measured pre and post treatment, the MRD1, the PFH, the superior scleral show, and the lag of thalamus showed statistically significant change. At the mean follow-up 16.3 months in our cases, MRD1 showed a reduction of 1.5 millimeters, which was statistically significant in all our cases. And there was no significant regression from the maximal response that was seen. And only one patient on the first follow-up showed a slight increase in intraocular pressure, which settled down by his next follow-up visit. So as we see, the questions that we started with can be answered by this simple injection that we use. That is the intra-LPS triamcinolone injection, which can be used as far as our study goes in active and inactive cases. A total of 1 to 4 injections were used. Long-term effect, it was the disease was stable in more than 6 months. There was no local side effects that we could see, no ocular side effects, and definitely it could be used in both functional as well as cosmetic concerns of the patient. And we had excellent results in all our cases. These are the few of the studies that have been done, and our studies also prove very gratifying results. And the mechanism proposed is anti-inflammatory effect on the Muller's or the LPS. These are all hypotheses that have been proposed for these injection, or aponeurotic detachment or myopathy causing ptosis. Even thinning of muscle has been described how this injection works. And although the studies say that targeting the inflammation in acute phase when we are ahead of the disease before the fibrosis actually sets in, it gives better result, but we could see the results in inactive disease also in our study. So the conclusion is effective and long-lasting modality is lacking. It is a challenging situation. And injections like triamcino, there is ease of administration. It has a short down time. It can be used during the active phase where nothing else can be used, like especially the surgery, and improve quality of life of the patient. And it definitely broadens our arsenal to help these patients. These are my references. Thank you so much.
What is the mean number of injections? Like how many injections per case you give?
It ranged from 1 to 4. Maximum 2 injections were required in most of our cases, sir. It
One
was
to four means
one
maximum.
injection. Yeah. So when we follow up, like we gave one injection and we follow up the patients after 6 to 8 weeks. If the retraction is still present and it is significant, we go ahead with the second injection. And basically, we clinically take a decision when to give the next injection. So few studies have actually followed up the patient exactly at 1 month, 3 months, 6 months. We did not follow up exactly at a same interval, but we followed up clinically as and when the patient were required to be followed up. And if it was a cosmetic concern for the patient, we went ahead according to their need of the injection, sir.
So maximum 4 and average 2.
Yes, sir.
Continuing with what Dr. Mukesh was asking, what was the clinical parameter which decided that you would need to repeat your injections?
So the superior scleral show. One is definitely, we had 2 categories of patient. Many patients wanted it for the cosmetic reasons also. So the superior scleral show was more than 1 millimeter. We went ahead with the injection. In severe cases, when there was too much of a lag of thalamus and the palpebral fissure height was so large that we had to give when the IVMP was going on. These injections were actually given when the IVMP cycles were going on for the patients. It was just for the local relief of the scleral show, sir. So that was the criteria that we kept.
Right. Thank you, Dr. Shaifali. Actually, nice presentation and nice concept now, which is coming on to treat lid retractions, especially in patients with thyroid orbital disease.
Yes, sir.
Because that is one component which is very difficult to treat.
Yes,
and
sir.
surgery was the only other option. So, do you know how it works? Can you just enlighten us?
So, sir, the hypothesis, as we say, like one is the depot of the drug that is there in the lid. It actually causes a kind of like a ptosis. One hypothesis is that. Second is the anti-inflammatory effect of the injection that has been proposed, because it's ultimately an autoimmune inflammatory disease. So we are actually acting on the inflammation that is going on in the lid. So 2-3 hypotheses, sir.
Right. Actually, the reason is very simple. We all know that chronic use of steroids intraocularly can cause ptosis.
Yes, sir.
So using that particular effect.
Yes.
To cause ptosis, right?
Yes.
But instead of putting it in the eye drops, because that can cause glaucoma and other problems, you have another route where you put it where you want it, and you hope that the same effects which cause ptosis kick in.
Yes.
Right. That's the reason why you need to give multiple doses in most of the patients.
Correct.
Right. So this causes stretching of the entire LPS complex, and that's how you get a ptosis.
Yes.
Thank you.
Thank you,
very
sir.
much.